Hey, today we have a very special treat for you. We're going to talk with Dr. Steve Bender, who is a very, very rare specialty in dentistry. You've been a dentist for 28 years, and the first half, 14 years, you were a restorative dentist, went to the Pankey Institute, all those things. But the last 14 years, you just specialize and only do pain, orofacial pain. Probably you're in Dallas, Plano, Texas. Probably the locals call it a TMJ. They probably don't call it TMD. How did you get into this? And are you glad you did that? Are you glad you went into pain?
Yeah, I mean, second question I'll answer first. I'm very glad. Every day, I feel very blessed to do what I do, and that I found this avenue of dentistry. I got into it probably from having problems myself. I grew up having migraine headaches, grew up having jaw pain, but probably really got interested just my experiences with my wife. She had some significant TMD issues, and this was right after I graduated, and we just couldn't find appropriate help for her. So through the process of being out of school, kind of developing a pattern of going to CE programs, I started getting really interested in those that dealt with temporomandibular joint disorders. And, that led me to Pankey, to Dawson. I took some of Mark Piper's courses. And then, about 10 years after graduating, I got a flyer from a course Henry Gremillion was teaching at the University of Florida. And it was more of a comprehensive pain course. And from that time on, I was hooked. I went through all their courses, and then he allowed me to do kind of a preceptorship over a 2-year period. And after that, it was like, do I want to be a restorative dentist or do I want to do pain? Because I found it difficult to do both. And so that's when I sold my practice and just started doing pain.
In Plano?
Yes.
Now,
Plano.
Is Plano a suburb of Dallas, or is it like an hour drive away, or is there rural country between Dallas and Plano, or is it just a suburb?
No, Plano is part of what we call the Metroplex. In other words, you look at Dallas and Fort Worth, and the two cities are almost connected with a bunch of little cities in between. So there is really just you go from Dallas to Plano, and you really can't tell. It's a big suburb.
And how many dentists in the United States would you say are like you that just do pain?
There's not many that do only pain. There's probably, a fair number that do a little bit of pain in their restorative practice. But I would say there's very few that do just pain. I couldn't give you a number.
And is this something that other dentists refer to you, or is this something you market and advertise yourself, or what percent of yours is referral versus marketing? Advertising?
We've done very little advertising. I did a little bit when I first started out. Put did a TV ad. Just very briefly. Put something in the newspaper, and then sent out a lot of letters to mostly dentists. But it's been pretty much we hit the ground running when we opened up, because I was getting in my restorative practice. People knew I was doing some of this TMJ type stuff, and so I was getting more and more referrals for that, and that's what drove me to want to get educated more. But it's primarily a referral from dentists, but we do get a lot of medical referrals too. A lot of internal medicine, neurologists, ENTs.
So walk us through, since I think most general dentists do not have a personal relationship with anybody that just does pain. I think a lot of our listeners, especially around the world, have never met anybody like you. So what is the average case? So a dentist has a patient with, patients. I know that it's TMD, but the brand is TMJ. I mean, all the patients in Phoenix call it TMJ.
Right.
So a dentist has a patient with TMJ. Maybe they've made a night guard, a flat, plain, 0-degree night guard. They don't have any odontic origin infections. They don't have root canals, fillings, crowns. All that's been fixed up. And what does this average patient look like when they're sent to you? Do they already have a 0-degree bite night guard, or?
Yeah, I would say most of them have. Most of them are dentist referred. Most of them have tried some kind of conservative therapy. I'd say less and less as I've gone on through the years. Are they coming in with night guards already? But still, probably the majority do. They have some kind of night guard, or some will bring in these big sacks of night guards, and nothing has really worked for them. So we have to kind of take a step back, kind of comprehensively look: is there anything that's being missed? And what about the night guard is not working, and what can we do to improve on it? Do we need to make a new one? So the average patient is probably a middle-aged female that's got some jaw joint pain, probably some headaches, and their general dentist has usually tried everything that they've known how to do to correct the problem.
And why would it be more likely to be a female than a male?
Well, part of the reason is more females are going to seek out care than males, but for a lot of different reasons, it seems like females tend to experience pain more than males do. It's not that they tolerate pain less. In fact, they probably tolerate it better than males, but their pain threshold seems to be lower. And again, that can be a lot of different things, but hormonal issues make a big part of it. That's why we see more females with migraine than we do in the male population.
And what do you say when you hear dentists talking about that industrial diseases, that richer countries like the United States, Korea, and Japan versus poorer countries like Jamaica have more brain spasm headaches, jaw spasm, TMJ, lower back spasm, the chiropractic industry, irritable bowel syndrome, angina, heart. How much of this do you think is stress in the world that we live in?
I definitely agree that stress is a big factor for a lot of different pain conditions. Stress is a factor, but it's not the factor. It's part of the big puzzle. So it can be a lot of different things. It can be our diet. It can be genetics. It can be, as I said, hormonal factors, and why that would differ from country to country, I don't know. But yes, getting back to your question, I think stress is definitely a factor, but it's not the factor.
And how's diet play into it?
Well, just the foods we eat not only affect us at a very localized area as far as what we eat, how it affects our jaw, but the nutrients we take in can have a factor too in our ability to tolerate pain. Our pain thresholds can be affected by the nutrition we get.
So walk us through a typical patient, and how do you do a workup, and what are you looking for, and what are you finding?
Well, the first thing we do is we ask them to fill out it's a pretty extensive form. It's about a 20-page form that covers a lot of different entities. In other words, I'm looking for headache types. If they've got headaches, I'm looking at sleep habits. I'm looking for a lot of different things. I'm asking them to describe their pain so I can get a rough idea and triage just from that intake form. And we ask them to send that back to us at least a couple days before. Number one, that tells us they're committed to coming, following through and seeing us. And number two, that gives me some background. So they come into the office, and we spend, before we even go back into the clinic setting, we just sit in our office here and talk for about 10, 15, 20 minutes, however long it takes, going through the form for clarity. But also, I want to hear verbally their story. I want to understand not only where's their pain, what is their pain, but how's it affecting them? How's it affecting their life? And so we do that, and I think that builds some rapport as well. They start to feel more comfortable, like I'm not just going to pigeonhole them into a slot and say you're TMJ or you're this or that, and give them a splint or a pill or something. So we do that, and then we go back into the exam room and we go through a pretty comprehensive exam. We're looking in their ears, we're looking in their eyes, their mouth, their nose. We're doing a cranial nerve examination. We're all obviously palpating the muscles and the joint structures, checking neck issues, range of motion. So we go through kind of a systems checklist from about the shoulders up, looking at different things. And then we go back into my office and we talk about, here's what we found, here's what it means, here's what normal is, here's where you are. In other words, I don't want them leaving until they have a very thorough understanding of what their pain complaint is, and that they see a plan that we're going to not just try things, but we're going to do specific targeted therapy, or we're going to refer them to the most appropriate either physician, dentist, whatever that they need. And so my hope is that they leave here feeling much better without even doing anything. And then obviously we schedule any kind of a treatment, whether it be to fabricate a splint, to do injection therapies, physical therapy, and we explain all those at that time. So it's about an hour and a half that they're here with us.
So what if you had 100 new patients, what percent would be female and what would be the average age?
Well, it's probably going to be 95% female.
Wow.
And they're going to be in the range of anywhere from 18 to 40 is the biggest range. Now that doesn't mean we do get some guys, and we do get older people, and we do get younger people, but the bulk of them is in that category.
Females 18 to 40.
Yeah.
And then so when you said some require a splint, some injection, some medication, talk about those.
Well, what do you mean?
Is the majority of them you're gonna do after your comprehensive exam, you're gonna do your own splint?
Yeah, I would say, since most people that come see me are some kind of temporomandibular disorder, probably the primary treatment that I do is some kind of oral device. And I used to try to modify existing devices, but I found that took a lot of time, and which incurred a lot of cost to the patient. So we usually start over, and I make all my splints myself. So we try to, I do a lot of work on an articulator, building these splints, and do a lot of fine tuning. And
is it hard acrylic on the maxilla?
Usually I do it on the mandibular.
Use the mandibular.
Yeah, I find people tolerate them better, and I tell people, look, I've done mandibular splints for so many years that really I feel like I can do a better job. Now, if they really don't like it, then we switch them. But I find most people tolerate and accept a lower splint, kind of a flat, plain splint for most people on the mandibular arch.
That's surprising, because if you ask me if the average dentist in the United States made 1 million splints, I would assume 99% were on the maxilla.
Yeah, and I think that's true because most that come in, that's where they are. That's what we were taught in school. They showed us that one way to make it in school. But you look at the research, there's not a lot of difference between one or the other. The one thing that's relatively new in the research is that if there's any kind of sleep-related breathing disorder, there is a chance that a maxillary splint will make it worse, whereas they have not found that in mandibular devices.
So do you put any clasp on the lower, or is it more just acrylic
more
retention?
Yeah. And we try to make that really comfortable. So I don't use clasps, and I find them to be well accepted.
Very, very good. And how many of these cases have a comorbidity with something else, like maybe sleep apnea or other holistic body, the oral systemic link issues?
Yeah. There's probably most of them that come in that it's not just one thing. They've got neck pain, they've got headaches, they've got sleep disorders. So it's rarely just jaw joint or jaw muscles.
So are you doing any of the sleep medicine stuff with them too, or?
I do. I mean, I really don't put myself out as, a sleep dentist, but a large part of what we do is make sleep apnea devices, refer them to sleep physicians if they need that, prescribe medicines for sleep if they need that. So that's a big part of the practice.
Yeah. So let's go pharmaceutical. What pills do you use, and is that a big? What percent of your patients would need a prescription, and what are some of your go-to meds, or is that more not as common?
There's not that many that I prescribe meds for. We do prescribe a lot of NSAIDs, anti-inflammatories, or maybe a steroid short-term dose pack or something for inflammation. Other medications, I like clonazepam, which is older benzodiazepine, because it's got a long half-life, so we can usually just prescribe it at bedtime. It has obviously anxiolytic effects, but it also has been shown to reduce movements during sleep. So I like it for that effect. And most of your benzodiazepines, or even some of the muscle relaxers, will have analgesic properties to them too. So clonazepam is a big one I use. I do use cyclobenzaprine fairly regularly. Again, muscle relaxers, well, I didn't say this, but muscle relaxers at the doses that we take them really don't relax muscles. We tend to need way higher doses of a muscle relaxer than we could tolerate. So what they do is they have some sedative properties to them, but they also have some pain relieving properties. So I use cyclobenzaprine, 5 milligrams, maybe, just at bedtime.
But if you had 100 patients, what percent would need a prescription?
Maybe 10.
10%. So 90% of the time, you don't even need pharmacy.
I'm not really using a lot of meds.
So what would you put up a course on Dental Town that was fantastic with a lot of great reviews about a year ago. Talk about that course, triaging headaches for the non-odonto.
Yeah, it was triaging the non-odontogenic toothache, or something about triaging facial pain. So what I tried to do was just go through kind of a sequence of here's different things that can present as either tooth pain or face pain, give kind of a diagnostic approach to looking at these, what characteristics they might present with. And unfortunately, there wasn't enough time to include treatment modalities. But my goal was to just give the dentist out there just some things to look at so they at least know what they're dealing with. And then once you know what you're dealing with, it makes treatment a lot easier.
So you're a specialist in this, and the general dentist, do you think the dental schools adequately train us in TMD?
No, in fact, I work at our dental school here part-time and here in Dallas at Baylor. And one thing that they've done that I wasn't aware of until just recently is they've consistently sent out surveys, post-graduation surveys at certain intervals up to about 5 to 10 years. And the most consistent thing that the dental graduate has not complained about, but felt their education was inadequate, was in pain, whether it be temporomandibular joint disorders or just diagnosing pain of the mouth. And so, no, I don't think that we get that enough in dental school, and there's some of us in this field that are trying to change that.
And Steve, what are some of the low-hanging fruit that a general dentist, say you're in a small town in rural America and you're busy, you're doing a lot of extractions and root canals and partials and crowns and fillings. What's the low-hanging fruit, that takeaway lessons you could help this guy out in small town America? It doesn't have a guy like you to refer to unless they put him on a plane. The most common thing a general dentist is going to encounter is probably temporomandibular issues, whether it be a popping joint or pain in the joint. And really just kind of going through a step-by-step process, a systematic approach, a very simple treatment is something they can do. I tell dentists all the time, you could manage this in your office. Number one, they tend to get better on their own most of the time. So even though they come in sometimes pretty significant pain, that the data tells us that most people are going to get better by themselves over time. So we can incorporate some non-steroidals, we can give them some muscle relaxers or something at bedtime, and then progress to maybe some physical therapy modalities, some passive stretching of the jaw, some ice, some heat, and then if needed, progress to just a basic splint. I said I do a lot of full flat plane splints. I use the NTI a lot also. And it's just kind of learning how to use those devices appropriately. I think the general dentist out there can solve a lot of those cases. So talk about that. When would you use an NTI over a flat plane mandibular splint?
Well, especially if I want to put somebody in a device right away. There's nothing better than just grabbing grabbing it out of the drawer, putting some thermoplastic material in it. And then obviously you want to, fine tune the occluding surface of it as per the protocol. But I'll tell you the cases that I wouldn't use it right away. And those are with the minimal overlap of their anterior teeth. If they're pretty close to no overlap, I really don't want to put them in a splint that may increase that. Over the years, and I've been using the NTI a long time, and I've had very few that their bites opened, but there has been a few. So that would be one thing that I would hesitate. But sometimes I do the flat plane because some people want something, they want something bigger, and they want something that looks like I spent a lot of time on it. And so that's, just in talking to them, that's when we kind of decide, okay, which device are we going to use here?
And would you say it's harder to keep an NTI in your mouth than a full arch?
No, not necessarily. I mean, there are some people with short clinical crowns that do make it difficult, and I usually don't try to do an NTI type device. But if you do, if you spend a little time with it, you can make them retentive enough where they don't pop out. I've never had anybody swallow them. I've just not had the bad side effects that some people claim.
Now, is there like a national organization where a dentist in all 50 states could find someone like you in their state to refer to?
Yeah, there's really two of the big ones. There's the Academy of Orofacial Pain, which I'm a member of that organization. And then there's also the American Academy of Craniofacial Pain. I used to belong to both, but I just had to decide which one I wanted to belong to. Both of them have very similar people in both groups. And so those are the two groups I would say for a dentist looking for either, number one, to educate themselves, look at those two groups, or to find a practitioner that could help them with cases.
And what's the www for that?
Well, the Academy of Orofacial Pain is www.aaop.org.
aaop.org.
Yeah, and I don't
Okay.
know about the other one. I don't
Okay.
I don't know what that one is.
Okay. And when would some more low-hanging fruit for that rural dentist who doesn't have a guy like you to work with, what would be a warning sign or red flags to where they need to get on the AAOPD and find someone? This isn't going to be an easy low-hanging fruit case. This is someone who needs someone more like you.
Well, if things don't make sense, in other words, if they have jaw pain, but you press on the jaw, move the jaw, and that doesn't duplicate the pain, that would be something you may want to further investigate. Now, if it's pain inside the mouth and they can't find anything that looks like, periapical pathology, in other words, they just don't see a reason for the pain, then they might want to investigate other causes, some kind of neuralgia, neuropathic pain. In other words, there's something else going on if you can't see anything. So when I teach courses, I always tell, one of my slides says, don't just try things. If a tooth hurts, but you don't see any problems, then don't try therapy. Look for something else.
Okay. So what else do you want to educate our viewers on?
Well, I don't know. I mean, you've asked some pretty good questions. The main thing I would say is that I've learned over the years is keep it simple. In other words, there's a lot of tools out there. There's a lot of toys out there, and some of them are good. Most are nice, but most are not needed. So you can differentially diagnose, you can effectively treat most pain conditions with really very conservative therapy. You don't need a lot of gadgets, although, the gadgets are fun. They give you some data.
Go through, because we see them a lot on people talking about it. Go through the top 10 gadgets and toys that dentists are buying and how can they help you? I mean, there's devices you can bite on and register your bites. Go through some of these.
Well,
there's products.
There are those products where you can bite on and get a sense of force distribution, which, I think is probably a good tool for a restorative dentist that's really trying to be meticulous about what they're doing. But as a diagnostic tool for somebody with, say, a temporomandibular joint disorder, bite force, in other words, where the teeth touch, has not been really shown to be a big issue, if any issue at all. So, understanding where the teeth are touching with somebody with just temporomandibular joint disorders is really not necessary. So I would say, yeah, that might be a good tool for a restorative dentist that really wants to do a fine job there, but it's not necessary for pain.
And what are the names of the top instruments that do that?
I don't know.
No.
I really don't know.
So then what you just said then, does that mean that that you're not doing a lot of equilibrations?
That's right. In fact,
because when I was in school 27 years ago, that was a go-to procedure when someone had TMD, is an equilibration, checking their bite, no prematurities.
Yeah, and there's still a lot of folks that do that. And I used to do a lot of them, especially when I went through the Pankey and Dawson courses. That was a treatment. I would equilibrate their bite. But I rarely do it. Well, I don't do it anymore. Now, there are cases where once we've treated people and we've uncovered, some significant bite issues, then I will refer to, either back to the dentist or a good prosthodontist and say, I think equilibrating this bite might be helpful. But that's rare. It's rare to see somebody, because most of the time when you treat somebody with a splint, all of a sudden when they get better, they don't notice their bite.
So back on the same argument 27 years ago, when I got out of school in 87, a lot of dentists said, well, if you got TMJ, your bite's so messed up, if you don't have a lot of crowns and bridges and fillings, you need orthodontics. Go to an orthodontist and get your bite fixed. What do you think of that modality?
Well, again, I think the data has kind of pushed that to the side now. It doesn't either support it or, in other words, braces don't necessarily cause TMD, but they don't also necessarily treat TMD. So in and of itself as a treatment is just not, the evidence doesn't support it.
Okay, so what would the evidence say is causing it then? Well, let me flip that around on you. What does the evidence say is probably causing this then?
The only thing that we can put a finger on and the evidence will say this caused that problem is trauma, direct trauma to the jaw. Everything else is speculated. We talk about trauma being either micro trauma or macro trauma. Macro would be, hit in the face, falling, things like that. And you can say, yes, A plus B equals C. Micro trauma is sustained trauma over time. And that can be sleep bruxism. It can be clenching during the day. It can be gum chewing, pencil chewing. And it's thought that these small little traumas repeated over a long period of time put excessive forces on the jaw joint. But again, that is somewhat speculative. And then everything else is just hypothetical as far as bite relationships, stress levels, hormones, all these other things that we talk about. So I would say that it's usually multifactorial, and most time we don't know unless somebody comes in and just says they fell or they got hit.
And is trauma in your practice in the last 14 years, has it been more car accident, or is it more domestic violence, or is it more trip and fall down and hit the ground?
The traumas that I've seen, and I can think of a couple fairly recently, a couple young men that were in fights. One was attacked at college, just kind of blindsided, and the other was a high school student, same thing, and they had sustained some fractures. The other trauma I saw today was a car accident where a young man hit his chin. And this was 2 years ago, and he's just progressively gotten worse over time. Sometimes we do suspect domestic violence, but I've never had anybody own up to it. In other words, you see certain signs, you have encounters with the spouse or the partner, and you have suspicions, but not enough where you could intervene in any way. So there are a few of those, not many.
And do you think any of this is, because sometimes you hear people say, well, I think I heard this when I was 10 years old and fell off a skateboard, and now they're 35. Do you think an accident on a bike or skateboard at 10 could manifest symptoms 2 or 3 decades later?
I think that it can. I think that it can set up the propensity to possibly have problems later. Because then you look at the other side and you've got all these people that had trauma at some point in their life and they've never had jaw problems, or they've got horrible occlusion and they've never had jaw problems. So we have to look at other factors. How adaptable is this individual? And again, I kind of go back to migraine. There's some of us that get migraine headaches through stimulation that doesn't bother other people, like strong odors gives me a migraine. The person sitting next to me may have no problem with it. So there's something in our brain that descending inhibitory mechanism, in other words, that filter that gets rid of all these signals for some people doesn't work for some of us. And so I think that an early age trauma has the potential in some individuals that maybe don't adapt as well to create problems later on. But you put on top of that, do they have sleep bruxism? Do they have other habits? Other things like that come into the picture.
And this is also why a lot of dentists probably aren't interested in this, because this is probably the most complex part of dentistry. I mean, it's involving the mind. It's so many comorbidity, other issues. It's not a simple, you have a cavity, you need an MO.
Right.
This tooth needs a root canal. Oh, let's try to get this crown to fit perfectly. I mean, this is probably the most complex part of dentistry, involving the human brain. Humans are so complex. So this is probably why it receives a lot of less interest.
Yeah, I mean, in dentistry, as you know, we are taught to look for a problem and then fix that problem. And I love what Jeff Okeson says, that pain is a thinking man's sport. We can't just see pain. You can't see it usually. And so we've got to use our minds to go through all the steps to figure out what's hurting, why it's hurting, and how do we help that.
Yeah, it reminds me of my wrestling coach in high school. He used to always scream and yell that there's no such thing as pain. You can't pour a glass of pain. You can't give me a pound of pain. It's all in your head. Just get rid of it. You're like, okay. Yeah. Sure feels like my arm hurts, but I guess if there's not a pound of it or a glass of it, it's all in my head.
Yeah, and that's the biggest hurdle that we see. Not only teaching undergraduate students, but also people that have been out for a while. Especially people that have been out of school for a while, because we were taught, in dentistry, you look for a problem. And if you don't find one, then you think there's a problem and you look to fix it somehow. You adjust the bite, you put orthodontics on them, you reposition their jaw. And really just doesn't, the evidence doesn't lead us that way, and the basics of pain are different.
So this is all you do. You're a specialist. So does this mean you do not have a hygienist, or do you have like just one operatory or 2 operatory? Or how does the logistics of this work? How many operatories do you have, and do you have a hygiene department?
No, I've got two operatories. I've got 1 assistant, and really we kind of kid back and forth that she really doesn't do much. She takes notes for me. She gets stuff that I need. She holds articulating paper. So, yeah, just 1 assistant, 2 operatories, no hygiene, no general dentistry, 1 person to answer the phone, and that's it.
So just 3 of you.
Yeah.
And
at times we've had 4, but right now we just got 3.
And do you bill insurance for this, or medical insurance, or just dental insurance, or all cash, or
everything? We are fee for service, and that helps us keep staff down, costs down. Everything we do is medical. So since we started doing just pain, we went from a dental model to a medical model. So everything is, and in medicine, as you may know, you have to have a diagnosis and a procedure. In dentistry, it's just procedures. So when we fill out these claim forms, we give them their diagnosis, give them the procedure code, and then they reimburse us at time of service. And then, we do what we can to help them get reimbursement. But we just found that if we stayed away from accepting assignment, we wouldn't have to hire somebody to be that insurance person, that insurance department. So that helps us keep costs down.
So they pay you, and then you help them file their insurance.
Right. We fill out the form for them. In other words, you can populate codes into a dental program. We use EagleSoft, but we use a health insurance claim form that just, I don't know what they do up there, but they just fill in the numbers. It gives them a form. We even address the envelope for them, and all they have to do is send it in. And then if there's, issues that come up, we might write letters and things like that.
And what percent of your patients will try to get reimbursement through their medical insurance?
Oh, I think all of them do. It's rare that somebody, I think it's rare that people say, I don't care I don't care about the insurance. So they all try to get reimbursement.
And is the new Affordable Health Care Act, also known as Obamacare, is that helping, hurting? Is that a factor, or is that not really a non-event?
It's not a factor for us yet, but I think people that do what I do over time, it will be a factor. It's like in a lot of our colleagues in orofacial pain or facial pain, we hang around with a lot of medical people, and we see what's happening with their practices. In other words, the small independent guy like me are being swallowed up by the corporate entities like a hospital or what they call a accountable care organization, which is basically a group of doctors. They're being forced into these big groups, in order to manage all the regulations of the Affordable Care Act. I think we're going to see, in what I do, I think we're going to see that happen. And I think eventually dentistry in general will see that happen as well, unfortunately.
So do you think this is a cyclical thing, or do you think America will, figure this out and then push back, or do you think the whole healthcare system is going to go the way of like Canada?
That's a good question, and I think we'll see, the next election cycle. But I've heard some people say, the toothpaste is already out of the tube, so it's going to be hard putting things back. So my guess, and that's all it is a guess, is that we are going to continue to change, and not for the good of those of us that are out here trying to help people.
Yeah, it'll be interesting time. So is there anything else you want to talk about?
Any other questions you have?
No, this is an amazing interview. Amazing interview. I think you've covered all your points. I think if the dentist needs to get help, he needs to go to the AAOPD.org. I think they should go to Dentaltown and watch your triaging the headache of the non-odontogenic toothache.
Actually, it's AAOP.org.
AAOPD.org?
No, AAOP.org.
Oh, okay. I added
No D.
The Academy of Orofacial Pain.
Orofacial pain, yes.
Orofacial pain. Orofacial.
Yeah. Yeah. Another good resource, there's some of us that hang around the TMD forum on Dentaltown, and, heck, I learn stuff all the time from some of the stuff that's posted on there. So, if that's a quick and easy way to just throw up a question and hopefully get a, respectable answer. Sometimes it gets a little testy, but I think it's a good resource. And, kudos to you for putting that together. It's an amazing thing that you've developed, and it's helped a lot of us out here.
Well, it's only amazing because guys like you have posted 5, 6, 7,000 times. We just have the software, but it's guys like you that make Dentaltown.
Well, it's fun, and it's I think it's a great thing.
Well, I want to thank you for, for all your posts on Dentaltown, for creating an online course, for taking time out of your schedule today to do an interview with me. And how can dentists contact you if they want to talk to you? Or
they can email me. Usually that's the best way to contact me, is by email.
Okay.
And that's steve@benderdds.com.
Benderdds.com.
Yeah. Usually I can't take phone calls during the day, so that's pretty difficult. So just, shoot me an email is the best way to contact me, and I'm happy to answer questions. Any question is okay.
And now that Dentaltown is coming up on 190,000 members with 3.5 million posts, a lot of your questions are already been asked on that TMD thread. Are there any threads you'd point them to in particularly, or just the forum in general?
I just scan the forum in general. There's so many different threads that I've forgotten most of them, but there's some really good ones. Um, and I can't emphasize enough. You'll see a lot of stuff about systems and devices. The best thing to do is keep it simple. You just don't need all the stuff out there that some people.
What I like most about Dental Town and reading those threads is, I've spent the night in hundreds of people's homes over 52 years of life. And if you spend the night at a dentist's house, just like behind you, they always got 100 books. And if you spend your night in someone who's not a dentist or a physician or lawyer, they only have 3 books. And one of them's 50 Shades of Grey and People magazine. And
Yeah.
when I'm reading those threads on Dental Town, someone will say something, and it's just very profound. I'm like, wow, that's really neat. And then the follow-up question, I'm usually like, oh, wow, I didn't even think of that. I mean, I didn't
Yeah.
even. So to see all these people with so many years of college, all pulling everything apart, and I always tease that you couldn't get 2 dentists to agree that it's October. The way they all see, the same X-ray, the same pano, the same symptoms, the same case, and they're all looking at this so many different ways, and it's really getting on down. It's like taking your mind out for a 10-mile run.
It really is. And what I've found that it's done over the years is it's driven me into the literature. In other words, I see something, I have a feeling about it, but I want to know more about it. And so I go to, I look it up. I look it up on PubMed or something and read about it. And so it's really driven me more to learn more. And so that's a good thing.
Yeah, and that's where the specialists are lucky like you. I mean, I always, not to throw you under a bus, but I'm always jealous of guys that just got to stay on top of like one thing. Like, because as a general dentist, we have to stay on top of so many things. It's crazy. I mean, you couldn't even get a dentist to be able to just name every bonding agent that Patterson sells. I mean, it's just overwhelming.
It is, and that's why I focus just on this. I don't have the mental capacity to do that. I can't keep up with the materials. I couldn't even focus from a pain patient to going into a hygiene check. That just blew my mind. So, yeah, I get it, and I admire people that do run a general practice.
There's only one area of dentistry that I've read all 5,000 PubMed citations on. You know what that is?
What is it?
Water fluoridation.
Oh, yeah.
That's the only one, because I was involved with that in Phoenix. So that's the only one where I can say, okay, I've read every single study on PubMed on that one area. But my gosh, when you leave that and go to like endo and bone grafts and form and then perio, and oh my God, it's so overwhelming. And I think that my prediction on the future of dentistry is it'll even be more specialist. I think right now the United States has 40,000 monthly journals to doctors, whether it be dentists, physicians, whatever, and that's just growing, and there's so much. I was talking to the guy the other day, and he's a patient. I said, he was an ophthalmologist. I said, oh, so you're an ophthalmologist, so you do glasses and all that? And he goes, no, it turns out that no, he only focused on the retina, but in the retina, just one area, one part of the retina. I mean, there's several, there's more than one specialty of just the retina, of just the eye. I mean, he does one thing. And that's overwhelming to him, and it's just amazing. But you need that guy if you're going to try to prevent blindness, and it's great there's guys.
I do think we'll see that in dentistry. I think that as we progress in education, we're going to see more and more where a dentist will have to choose a specialty. In other words, you can't just do your 4 years and go out. You can choose to be a general practice practitioner, but you're going to have to do a residency for it. So I think we're going to see a trend that we follow medicine into mandatory residencies, fellowships, whatever, to get licensed.
And I can't let you off the hook without asking one question. Did you think a year ago today that the Cowboys would be have 6 victories? What are they?
I did not.
What are they? 6-2?
6-2. No, I had them because we've been 8-8 for the last few years. I had them pegged at less than 500. I didn't see them doing what they've done. So it's been exciting.
I'm going to be very nervous this Sunday because my Arizona Cardinals are flying out to Dallas to meet you guys in the stadium. That's the biggest, newest $1 billion stadium, right? Doesn't it hold like 100,000 people?
Close to 100,000. It's
wow.
it's an amazing structure. I've never
So-
seen anything like it.
So I'm going to pin you to it. What's the score going to be at the end of the day on Sunday? Cardinals versus Dallas. Who's going to win and what's the score?
I say Cardinals probably 27-21.
You think the Cardinals are going to win
I do.
in
I think
Dallas?
I think their defense is pretty stout, and I don't know that our offense can. I don't know that our defense can outplay the Cardinals' defense, if that makes any sense.
Well, you just made my day.
Well, that's what I'm here for.
Okay, well, Steve, again, thanks for everything you do for dentistry, for your patients, and for Dental Town. Thank you for putting up a course, your 1,000, 6,000 plus posts, everything you do. It's been fantastic. Thank you very much.
Hey, thank you. I appreciate you.
All right, thanks, buddy. Bye-bye.
Talk to you later.